Okay, this is part 2 of Cell Pathology and Infection Lecture 2. So here we are covering tumour stage as opposed to the previous session, which was tumour grade. So tumour stage is a description of how far the tumour has spread or how large the tumour is. And to do this we have various codes, we have various names that allow us to describe a tumour so that a pathologist or a clinician can understand exactly what that tumour burden is likely to be within that patient. So one of the most widely used tumour staging systems is the TNM system, Tumour Node Metastasis System, and this is shown here. And there's a neat little book called the TNM Atlas which shows the TNM staging for most solid tumour types, and the TNM system goes from T of 0 up to 4, although it's only shown for 3 on this particular case. So nodes is 0, 1 or 2, whether it's local or distant, and then metastasis can be 0 for absent, 1 for maybe some, the presence of something, and then you can maybe have 1A, B or C for different sites. And in some cases distant lymph nodes would come under M. In other tumour types, distant lymph nodes comes under the N setting or category. So the TNM Atlas is the place to look for details on that. I'll show you just some examples in this session. But the sort of codes that you'll get is something like T3, which means a fairly large tumour. T3 N1 M1 would mean a relatively large tumour with local lymph nodes involved and some distant metastasis involved. So that's the type of code that we could be dealing with. So T3 N1 M1 is much worse than a T2 N0 M0. And when you're reading studies on clinical trials in particular, patients are often stratified on their TNM score to decide whether they are in or out of a clinical trial. If the clinical trial is for late stage cancer, it would include positivity of either lymph nodes or distant metastasis, or possibly T4, which would be a very large tumour sort of invading into all their tissues. So early stage would be like a T1 or T2 with the absence of lymph node or distant metastasis. Late stage will be T3 with distant or local lymph node involvement. Now in addition to that, we can have the clinical stage and the pathological stage. So this can be like a prefix on the TNM staging system. So a little c means clinical stage, and that's basically all the information that you've got at the time of doing that staging, often before surgery. And then pathological staging is taking information that has been gained from, quite often from surgery as well. So you can have patients who go into an operating theatre and we think it's a T2 N0 M0, which is an entirely operative tumour, one that could be cured by surgery. And sometimes in surgery we find that the tumour is actually bigger than we thought, and it's spread around, that maybe if it's an ovarian cancer that's T2 on imaging, but we get in there and in surgery you find that it's actually invaded local tissues, and it may well be T3 or N1 or M1. So basically what can happen is tumours can be upstaged during surgery. So they go in low stage and then we find out more information, and the patients are then sometimes upstaged. Okay, so this slide shows the TNM staging of prostate tumours, and there's a lot of information, but it's a good idea to just be able to follow the general pattern of what is going on. So we're dealing with T0 to 4. So T0 is no evidence of primary tumour. TIS is a carcinoma in situ, so you will be looking at intraepithelial neoplasia, as we saw in the previous video. Then T1 is fully fledged cancer, and basically it's clinically unapparent or not palpable. So that basically means that it's likely to be somebody who has been picked up by some sort of screening with raised prostate specific antigen levels, which is prostate-specific protein that ends up in blood when you've got cancer, although doesn't mean you've got cancer, it just is raised in cancer. So a T1 is clinically unapparent, not palpable, so you can't feel the tumour on a digital rectal examination. And a T1C specifically is one that's only found on biopsy. So that's where you don't know there's a tumour there, but you're going to biopsy it anyway because you've got raised PSA. T2 is slightly larger. So T2A involves just one lobe, T2B more than half of one lobe, and T2C involves both lobes, but it's still within the prostatic capsule. So T1, you can't feel it, it's clinically inapparent. T2, you would be able to feel that by a digital rectal examination, and you'll be able to easily see it on imaging as well. Whereas in T3, this is a tumour that extends throughout the prostatic capsule, and T3A has gone extracapsular, like this one has. T3B has invaded the seminal vesicles. So the distinction here is T2s are confined to the prostate, T3s have started to break out of the prostate, T4s are much larger and they've extended throughout the prostate and could involve the bladder and rectal wall. So these are as severe as a cancer that's got distant metastasis. Certainly in terms of survival as well, these are very, very advanced. These are really also quite advanced, and surgery is rarely even attempted on these. It can be attempted, but not all that commonly. Whereas both of these two are curative by surgery, and that's because the tumour is confined within the prostate, and you hope it's not spread any further, and if you remove the prostate, you cure the patient with surgery. So in terms of, even if you can't remember all the individual details of the substages, it doesn't matter as long as you can appreciate that a tumour confined to the prostate can be cured by surgery. A tumour that extends beyond the prostatic capsule cannot be cured by surgery because it's already spread beyond the prostate. And that sort of tumour, T3 and T4, are always treated with a systemic therapy, which is, in this case, anti-androgen therapy, whereas T1 and T2s are often treated locally. That would be local surgery or local radiotherapy. And then if the tumours are high grade, you might also give a systemic anti-androgen therapy as well, just in case they have already spread. So much like the question of why is tumour grade so important, and we saw that patients with high grade disease are likely to die quicker, tumour stage is also very, very important. And what we can see here, this is the death rate of patients years after surgery for T2, T3s and T4s. T1s are not shown, they have very good long-term survival. So what you can see is with increasing burden there is a very rapid shift. If we look at the disease-specific survival, so this is basically patients who are dying from their prostate cancer or its direct complications, the T2s don't even get to 50% in 15 years. So we can't calculate a 50% survival. For T3As, we can calculate about 8-9 years. T3Bs, it's substantially shorter, for 4 years-ish. T3Cs, 2 years. And a patient who comes in and presents with a T4 cancer is likely to 50% survival of about 18 months, which is a very, very poor prognosis. And you see some of these patients die within weeks of being diagnosed. Conversely, some of them survive long term. Now these that survive long term are ones that are managed on anti-androgen therapy very, very well. So if a patient comes in with a very large tumour that doesn't respond to anti-androgens, there is very little that can be done for those patients. Whereas a patient might come in with a very extensive tumour, but that might just happen to respond to anti-androgens very well, and in a minority of these cases, they'll survive long term. So just knowing that it's a T4 cancer doesn't mean that the patient is definitely going to have a very short lifespan, but we are looking at about 1 in 5 cases having a significant long-term survival managed on anti-androgens. So what we can do is start to look at what therapies are available for patients by tumour stage, just by T stage. So T1 and T2As, these are the very small tumours. We do either radical prostatectomy, that's surgery, external beam radiotherapy, so that's extra gamma rays delivered external to the body with a linear accelerator, and we also do implant radiation therapy, which is radioactive seeds implanted within the prostate around the tumour, and they are left in situ to kill the tumour. They are all equally as good as each other, sort of, along with active surveillance. And active surveillance is literally monitoring the patient, measuring prostate-specific antigen levels every few months, and not doing anything to the patient until they show signs of tumour growing. Now, this is often patients who are also a low Gleason sum score. So if you come in with a Gleason sum score of 2 or 3 and it's a T1 cancer, is very, very little point in performing a major operation, because that tumour is very unlikely to kill that patient in the next 15 years. So the patients are offered active surveillance, and if the PSA levels start to shoot up, then yes, you can start thinking about either radiotherapy or surgery. And the evidence to show that these are all equally good, or very close to equally good, was performed in a big study done at my old department at the University of Sheffield, and it was a study called the PROTECT trial, where patients came in and were randomised onto one of these different therapies. And the data for this is still coming out, because this was started about 12, 13 years ago, but we are now getting 5 and 10 year survival data showing that all of these therapies have a very good outcome, and certainly active surveillance is not significantly reducing tumour survival from these tumours. When we start getting to a slightly larger T2B to TC, so we're getting a large proportion of one lobe or both lobes involved, then radical prostatectomy and implant radiation are as equally as good as each other, and then we start looking at external beam radiotherapy and putting in hormone therapy if you've got a high Gleason grade. Once we get up to T3, we stop routinely doing local therapy and we go in straight with hormone therapy, which is systemic, because we assume it's a T3, by all likelihood it's already spread, and therefore we're going to give a systemic therapy. So hormone therapy is the most likely, external beam radiotherapy with hormone therapy if it's high Gleason grade. If it's a low Gleason grade, then radical prostatectomy might still be offered, but you wouldn't do that if it's a high Gleason grade. That would be a low Gleason grade situation. So that's the most likely series of events. When you get up to T4s, giving anything locally we know is futile, so we're giving hormone therapy. A lot of these therapies are often palliative, that is to relieve the symptoms. So we can irradiate the prostate area by external beam radiotherapy, we can give hormone therapy, and that will slow down tumour growth or stop tumour growth for a period of time, and that will alleviate symptoms, especially if those prostate cancer cells are invading into the bladder, invading into the bowel, or compressing the urethra. Often radiotherapy is given purely as a palliative measure, because if you irradiate the tumour, you will be able to shrink it down in size. You won't be able to cure the patient, but you will be able to vastly reduce the symptoms. Any patient that comes in with N1, which is lymph node involvement, or M1A to C. M1A to C is bone marrow, brain and distant lymph nodes that are involved, but they'll be treated in the same way as a T4 patient. You start immediately on a systemic treatment. So what you can see is we've gone from local treatment or no treatment, so no treatment, local treatment with possibly systemic treatment if it's high Gleason grade, to here where we're going in most likely systemic treatment. You'd only do local treatment if it was low Gleason grade, and then in the high T scores, this is advanced cancer, this is T4, we'll call it stage 4 as well when we look onto another staging system. You go in with purely systemic treatment and often palliative therapy. Now there are a few other staging systems that are sort tumour specific, one of which is colon cancer. There's a Duke's classification that has 4 stages, which loosely match on to the TNM classification. So stage A is limited to the mucosa, B is extending into the bowel wall, and the later stages are tumours that are invading deeper into the bowel wall. And this is partly because, in a way, it's not so much the size of the tumour that matters, it's how far they've extended down into the bowel wall, because that describes how likely it is that these tumours have spread. You could have a large-ish tumour that hasn't invaded down into the bowel wall, which could be a T1. So that's why this modification of a TNM type system is required for the colon in particular. And it does match on very closely to the TNM system for that tumour type anyway. So T1, T2. So T1 is just in sub mucosa, which is Duke's A. So they are superficially very, very similar. Other tumour-specific staging systems include all of the gynecological cancers, so cervical, endometrial. They come under the FIGO staging system, which I may well cover in a later lecture. And there's also more sort of generic staging that you'll hear about, and what most people know is that stage 4 is not good. So there, if you click on this link here, this is a link to the American Cancer Institute, or National Cancer Institute in America, which has this is where this is from, and this just highlights stage 0, which is like carcinoma in situ. It's not spread to nearby tissues. Stage 1, 2 and 3 just represent increasingly large tumours, whereas stage 4 is classed as spread to different parts of the body. So stage 4 is the same as having something with an M1 or an N1 on it, with this nomenclature. So different people and different specialities use different staging systems. There's also this one here where you can refer to it as in situ, which is like carcinoma in situ. Localized, that's just a primary cancer that's not shown any signs of spread. Regional, where it may have gone to the nearby lymph nodes but not distant lymph nodes. And then distant is gone to either distant lymph nodes or a different part of the body. So this is a summary of everything we've covered. The first video covered everything to do with tumour grade. We've just covered tumour stage, mostly the TNM system. I mentioned some other systems. What you might want to think about is how tumour grade could be used with tumour stage to come to an even better conclusion. We know that tumour grade, high grade, you have poor survival. High stage or late stage, you have poor survival. But what about if you combine those together? So it may well be worth, at this point, looking up the Nottingham Prognostic Index. So the Nottingham Prognostic Index, which takes into account both tumour grade and tumour stage, and this comes up with a score that combines both grade and stage together to give a very good predictor of likely recurrence from the primary tumour after surgery. So it's well worth looking at the Nottingham Prognostic Index, because tumour grade and tumour stage are not used in isolation, they tend to be used together. Okay, that's the end of this session.